Associate Professor of Medical Gerontology in Trinity College. He is Director of the Institute for Memory and Cognition and the Cognitive Clinical Trials Unit in Tala University Hospital, Dublin. He is Clinical Director of the National Intellectual Disability Memory Service in Tala University Hospital, and he is co-lead investigator on the Health Research Board funded Dementia Trials Ireland and National Clinical Trials Network, and is principal investigator for the Health Research Board funded of Dementia Research Network Ireland. We also have Vanessa Moore, and Vanessa is the Scientific Project Manager of Dementia Research Network Ireland. Vanessa has a PhD from the School of Social Work and Social Policy, Trinity College Dublin, where her research centred on the lived experience of people with young onset dementia in Ireland. She has an MSc in Applied Social Research from TCD and an MA International Relations from University College Cork. And before taking up her role at DRNI, Vanessa was a senior researcher here at the University, or at the European Institute of Women's Health. And Vanessa also worked as a research assistant at the Living with Dementia program in TCD. So we're really looking forward to just an interesting presentation this morning. Vanessa, could I turn to you first? It is such an important issue for the Women's Health Task Force and women in general. We have an ageing population and a rise in dementia prevalence numbers. Can you give us some insights into the impact of women, particularly in their role in society? I give the floor to you, Vanessa.
Thanks so much, Peggy. I'll start sharing my slides. So I hope this works now. Let's see. Now, can everybody see that?
That's perfect.
Great. Okay, so I'll get started. So yes, I'm going to talk about the social aspect of dementia in women. So before, there we go. So before I start, I'm just going to speak a little bit just about DRNI briefly. So DRNI, Dementia Research Networks Ireland, it was established in June 2012. It's an innovative all-Ireland interdisciplinary dementia and neurodegenerative research initiative. What does that actually mean? So basically what DRNI does, our aim is to bring together all the different types of research that takes place in the area of dementia and neurodegeneration across the island of Ireland, so incorporating the north as well. The three main strands of research would be basic science, clinical science, and then social science and kind of health science research. It's funded by the HRB and it's currently being hosted by Trinity College Dublin. The membership stands currently at around 150 members. The membership is quite diverse. It's from a wide variety of disciplines and background. Like I said, basic science, clinical science, social science, but also, you have a lot of different, say, for example, a lot of healthcare professionals, social scientists, sociologists, any kind. So we have a quite diverse membership, which is great because that's what we, really want to capture all the different levels of research that's taking place in Ireland in relation to dementia and neurodegeneration. So just to move into women and dementia, sorry, I don't know what my slides are doing here. Okay, there we go. So the biological and gendered experiences that you experience across your life course will affect your brain health and dementia risk. So Sean is going to talk about that later. So I'm not going to go into it too much, but there's socioeconomic disparities will shape your kind of health trajectories as they affect you throughout the life course, and there's a lot of structural society factors that play into that. As I'm sure you all know, there's plenty of social determinants of health, that really will affect how you kind of age. One of the main protective factors against developing dementia in later life is to develop good brain resilience. So Sean is going to talk about that in more detail, but good brain resilience together with physical activity, healthy eating, and kind of, again, training your brain resilience through intellectual development, mental activity, higher education, socialization, all can contribute to delaying the onset of dementia. Historically, women would have had fewer opportunities to pursue higher levels of education, which may therefore increase risk of developing dementia and just kind of this brain resilience. Also, having this kind of higher cognitive reserve of brain resilience It's not acquired solely through education, but also through kind of ongoing cognitive, social, and physically stimulating activities that you can do to kind of, help your brain. Many women would not have been in full-time paid employment in various times of their adult life, quite often because of caring responsibilities, such as women taking, going down to part-time or even giving up work for a while when they have small children, or maybe caring responsibilities for older relatives. The knock-on effect of that is having a smaller pension when they become older. Women are more likely to live in poverty in old age. This all contributes to a lower income than men for women. Also, there's the, which we're all very familiar with, the gender pay gap. So, kind of exacerbates the situation a bit. The end result is that women have fewer financial means. This includes then, limiting women pursuing stimulating activities, and also to look after their own health. And as I'm sure a lot of you know as well, women do have while women live longer, they have longer, even less healthy life years. In terms of caregiving then, women are disproportionately affected by dementia. Sean is going to talk more about that, so I'm not skipping through it, but they also bear the bulk of caregiving, and this is really important to talk about because it's so predominantly for women. The overall cost of dementia in Ireland is just over 1.69 billion per year, and 48% of this, so very close to half, is attributable to family care, and that's generally, not solely, but it's generally that's generally women who do this family care. And that's the same across Europe, and I dare say the world. Women provide the bulk of informal care. Between 60 and 70% of all carers are women. Women are 2.5 times more likely than men to provide the care when they live with the care recipient. So often that would be for a spouse, or perhaps, your older relative is living with you. Caregiving, and there's a broad range of stress that you can experience as a direct result of caregiving. While there's benefits from caregiving in the sense of, you might get great, pleasure from being able to help your older relative, and it might be enjoyable to spend that time together. There is an awful lot of stress that comes with it as well. I'm sure you're familiar with this. Physical and psychological well-being is affected, and women tend to experience this more. They report higher level of stress, higher levels of depression and anxiety symptoms, and they also report lower levels of quality of life. Women also tend to provide care for a longer period of time than men, and they also spend more hours per day helping with tasks of activities of daily living and instrumental activities of daily living. So, the very basic, helping with getting dressed, toileting, preparing food, like the very basic things, plus everything else. Male caregivers, interestingly enough, are more likely to receive formal practical support, and they're also more likely to use external resources than women to care for their spouses, and they're also more willing to accept help to enhance the level of support they could provide. It's a bit unclear why that's the case. It's believed that women tend to not want to kind of disturb. They don't want to they don't want to take resources away from other people. Also, they are maybe less likely to admit that they're struggling. So there's a few different things in there that really needs to be unpicked. Caregivers of people with dementia often have to make changes to their employment situation. So this goes back to what we spoke about earlier about working part-time. And women are more likely than men to reduce their hours to part-time or to stop work completely to be able to provide care. So whether you're a male or female caregiver, if you're female, you're more likely to reduce your hours. Interestingly, daughters acting as the primary caregivers also report higher burden levels of care than sons. So similar to spouses, where the man doesn't report such high levels. So they have a higher depression levels. They're also more likely to have care responsibilities for their children. So it's that sandwich generation, as they're called. So you're caring for your children, you're caring for your parent with dementia. Then in the middle of that, you're trying to work and care for your own household. So there's a lot of competing roles that lead to a lot of stress and conflict for the carer. Another aspect of women in dementia is women who are in the care workforce. So women make up by far the largest portion of professional care workforce in dementia. So whether that's formal healthcare or social care, supporting the person with dementia and their caregivers. So, you know, for example, the social care worker who comes into the home to, you know, the home help who comes into the person with dementia and their caregiver. This workforce is predominantly female. The standing of this workforce, both in terms of financial rewards and social status, is quite low. Formal care is provided by women under very challenging circumstances, high workloads, there's a lot of time pressure, lack of support maybe from the employers, and also low paid, low status jobs with short term or unstable contracts. So, you know, there's a lot in that creates a lot of stress before you even started your job, so to say. So that's a big impact as well. Also, the gender pay gap for people working within the health and social care environment means that the earnings for women compared to men in the similar role is about 10% lower. So that's a big difference from an already low paid job. The study that found that is about 10 years old. It'd be interesting to see if that's changed in the meantime, but who knows? So what can kind of be done about this? How can this be challenged? So more research is always needed. So more research and further analysis is needed on both the biological impact and gendered nature of dementia, to understand the risk and to assess the risk, assess the need, what's needed, you know, what's arising out of that, and how can we dedicate the right available resources for that. An improvement in both the health and social systems to kind of facilitate living with dementia and to support the person with dementia and their carers would go a great deal to improving the impact. And also, it's really important to focus on embedding gendered issues in the development of all and any dementia policies that get created. So gender mainstreaming, basically, where gender is considered from the very, very outset, especially when it's a well-known factor in the issues. So, for example, the Irish National Dementia Strategy recognises gender as a non-modifiable risk factor associated with dementia, which is a great start. You know, it does officially recognise that. It says that it's, you know, it's something that they're already very aware of. So, you know, that's a great building block. So you can start with, you know, that's already been started. You can continue to build on then onto that then in terms of developing, you know, both policies, but even to know where to, you know, direct, for example, funding for research. Finally, also, it's really important to review, okay, what supports are currently available and what's required to meet these future needs. You know, so we have, Sean will talk more about it, but, you know, we kind of know roughly kind of numbers and, you know, what's coming down the line, where are the pinch points, and, you know, once that's known, it's a lot easier to review how to best support that in the future to avoid these kind of issues becoming overwhelming. So there's plenty to be done in that area to facilitate the future. I think, yes, that's it. So thanks very much for your time. And that's just the some of the references there. And I will hand back over to you, Peggy. Oh, I think you're on mute there, Peggy.
Always forget that one. Listen, thank you very much, Vanessa, for an excellent presentation. I mean, it just shows the personal, economic and social consequences of dementia are significant for women and severely compromises quality of life for the individuals affected and their carers and families. So thank you very much, Vanessa. But Sean, I'd like to come to you now, and you know, just based on what Vanessa said, you know, from the scientific perspective, it's estimated that dementia will overtake cardiovascular disease to become the leading cause of mortality in the top sort of the next 10 years, 20 years. And the worrying thing is the only condition in the top 10 causes of death without a treatment to prevent, cure or slow its progress. So very interested to hear your insights and your expertise from your vast expertise across the whole sector. Thank you very much, Sean. Over to you.
Thanks so much, Peggy, and thank you so much for the opportunity to speak on this topic this morning. I think it's so important, and you know, perhaps the most important thing that we need to take out of this talk and other talks is the need to raise public awareness of this. So there's this huge disparity in that the traditional model of research has kind of controlled for gender differences in these major conditions, such as cardiovascular disease and cancer between men and women. So when we're doing our large analysis, actually, we try and control statistically for gender differences as opposed to exploring those gender differences. What's happened with regards to dementia, in particular Alzheimer's disease, is over the last decade, people have said, hang on a minute, this may not just be an age effect whereby women are living longer, and that there may be biological reasons as to why this is more prominent. And it's led to a greater exploration and understanding of it. So there needs to be very clear public health messaging. I'm just going to share some slides here to kind of maybe take a step backwards and go through some of the terminology around this condition and how we manage it. As we mentioned earlier on, I'm a clinician, first and foremost. I work in a memory service where we diagnose people of all ages. And the youngest person I diagnosed with Alzheimer's disease was a lady in her 30s. And most of the younger people that I diagnosed with Alzheimer's disease are women. And when we kind of take a step back to understand the terminology, dementia is often ascribed the status of being a diagnosis in its own right, but actually, saying that somebody has dementia is akin to saying that they have shortness of breath. It doesn't tell you what's causing it. The term dementia refers to a memory or thinking difficulty which causes impairment in their daily activities. So even though it's synonymous with memory, actually function is the key element of dementia. The difference between a memory nuisance and a memory problem, which is dementia, is actually where, as a result of that memory difficulty or language difficulty or visual difficulty, somebody has functional decline. And the most common question I get asked in clinic is, what's the difference between Alzheimer's disease and dementia? Well, if we take the analogy of dementia being like saying somebody is breathless, saying that, you have Alzheimer's disease, it tells you what's the cause of that, memory of that functional loss. And Alzheimer's disease is the most common cause of dementia. So it's a bit like saying that as a result of somebody having cardiac disease, they're short of breath. Alzheimer's disease is caused by two specific proteins that build up in the brain, and I'll talk a little bit about them later on. But there are other causes of dementia. So we know stroke and vascular diseases account for about 10% of causes of dementia. Parkinson's related dementia, so dementia with Lewy bodies or dementia that arises when people have Parkinson's disease can occur in another 10 or 15%. And frontotemporal dementia and other unusual causes account for the other causes. And what we understand over the last 15 years in particular is that all of these different causes of dementia, be it Alzheimer's disease or these Parkinson's disease or frontotemporal dementia, they're all caused by abnormal buildup of toxic proteins in the brain. For Alzheimer's disease, it's these two proteins, amyloid beta or A beta and tau. And as a result of those proteins building up in the brain, they cause the death of brain cells. And as a result of us identifying those proteins, of course, similar to what we did with COVID, when we identify what a pathology is, we can work on developing medicines and drugs to target those protein accumulations. And I'll talk about some exciting developments in that area that's happening at the moment. Of course, the brain itself, I often try and describe the brain as like a fuse board. So depending on the area of the brain that these proteins accumulate, you're going to get different symptoms. And perhaps one of the most confusing things for people when they come into the clinic and they're talking is they're trying to reference their experience of having a memory difficulty with that of maybe somebody that they've known or that they've cared for before. And of course, if these proteins build up in the frontal part of your brain, you may get symptoms of aggression or disinhibition. If they build up in the posterior part of the brain, you may get visual symptoms whereby you may get hallucinations or have difficulty with depth perceptions. If they build up in this temporal lobe of the brain, that's often where you'll get either memory symptoms, and typically this is the area that's most affected by Parkinson's disease, that on this parietal lobe, which is or if you like that where our sensory inputs come into, and it's responsible for a lot of our dexterity. So depending on where these proteins build up in the brain, you may get behavioral changes, memory changes, or visual changes. But there can be variation in this, and that the proteins that cause Alzheimer's disease won't necessarily always build up in that temporal area. Sometimes they can build up in different parts of the brain, and this is where it kind of gets challenging or confusing for individuals, because their symptoms of Alzheimer's disease might be quite different to somebody that they knew before. But typically we know that the presentation of somebody's dementia symptoms is related to the type of protein that accumulates within the brain, the toxic accumulation, and the area of the brain that's affected, in particular the area that's affected most at first. And that just reiterates that. So increasing age is the biggest risk factor for developing dementia. We know that, at the age of 65, about 1 in 20 people are, may have dementia. That goes up to about 20% of people, 1 in 5 at the age of 80, and almost 40% or 1 in 2 at the age of 90. And of course that has great context within the within the aging demography. The successful story that is are living longer and living healthier by and large that we have in Ireland now. But as a result, despite the fact that if we take 40 years ago, an individual at the age of 80 was 40% more likely to have dementia 40 years ago than they are now. So the age-adjusted risk is much lower nowadays as a result of better blood pressure control, cholesterol control, better education and cognitive stimulation. But by virtue of the increased numbers that we're seeing in that aging population, the numbers, we currently have about 66,000 people living with dementia in Ireland. That's expected to grow over the next decade or so to about 113,000 and probably will exceed 150,000 over the next 25 years. All to do with that number of people over the age of 65. The other thing that's really interesting, though, at the age of 90, about 60% of people have sufficient brain pathology, so have sufficient amounts of these toxic proteins in the brain that they should have dementia, but many of them don't. So this is where that whole concept of brain health came from. We identified that there was this group of, if you like, for want of a better term, super agers, who despite having all of these potential negative proteins in the brain, didn't go on to develop dementia. So we started looking at what was it they did in their life that was different. This is the crux as to why we're having this talk today. The estimated lifetime risk is, and some clinicians have referred to Alzheimer's disease as a female condition. I think that's probably an overstatement, but what there is a very clear female predisposition for Alzheimer's disease, and in fact for other dementias, whereby it affects women 2 to 1 versus men. We know that that happens whether we look at in younger age or in later life. That risk seems to remain consistent. This is, for many years, it was ascribed that this risk was due to the fact that women were living longer, and as a result, age being the biggest risk factor, and that this accounted for this. We now know by controlling for age and by seeing actually the increased life expectancy in males that we're still seeing this divergent pattern of developing dementia across the two genders. And then exactly as Vanessa mentioned, we also know there's a whole inequitable impact of women on the role of the care supporter. So 2/3 of dementia caregivers are women, over 1/3 of those are daughters. It's far more common for wives to support their husband than vice versa, and women provide more care in hours per week and for more years, and caregivers who are women experience higher levels of burden, low mood, depression and impaired health than men. So we can see this whole inequitable impact of Alzheimer's disease and dementia, and this is all statistics that have come from the international data from the Alzheimer's Association. One of the big advances that we've had over the last 10-15 years is the development of what we call biomarkers. And biomarkers are essentially tests that I can apply to accurately ascribe a diagnosis to somebody. And up until about 2010, 2011, essentially our diagnostic criteria for Alzheimer's disease was, if the clinician seeing you can't think of anything better that it might be, it's probably Alzheimer's disease, which I think we would all state, we would all acknowledge was a very, very poor. And that's just up until the last 10 or 15 years. What's happened over the last 15 years is we've become far more sophisticated at identifying risk factors and how and the cognitive tests we're able to do. We've got much better at looking at how we interpret MRI scans and things like PET scans, which are able to show the activity in different regions of the brain, and we know that the different activity in different regions of the brain could correlate with the cause of dementia. But perhaps most importantly, we're able to identify and measure. So the only way up until about 7 or 8 years ago that I could definitively give information to somebody that they had Alzheimer's disease was really a post-mortem study after they had passed away if we examined their brain. Now we're able to do a test called CSF biomarkers, whereby we were able to give a little bit of a local anesthetic, numb the back, and measure these proteins within their brain. And we do about 150 or 200 of those in the memory service here in Tallaght per year. It's a very well tolerated procedure, and I'm happy to chat a bit more about it if people want to know about it. But the benefit is that we're able to get very clear diagnosis as to what is causing people's memory difficulty, and we're able to do it at a stage that they're able to understand it. Rapidly developing is far less invasive blood tests, which I would expect over the next 2 years will become commonly available, that are able to replicate a lot of the sensitivity of these CSF tests. So I'll talk a little bit about what I think is the future picture for a clinical treatment for Alzheimer's disease when I get a little bit towards the end of the study. But ultimately, what we know is these tau proteins and these amyloid proteins, they accumulate in the brain. The tau proteins are within the brain cells, within the brain neurons, and as a result, if you like, they kill those brain cells from within. The tau proteins are outside the brain cells, and they cause shrinkage by pruning these synapses that connect to other brain cells. So it's if you like, it's a war of attrition. The changes in these the accumulation of these proteins then cause to this shrinkage that we see in the brain. And particularly if we look at this area here, this is the memory center called our medial temporal lobe, and we can see very selective shrinkage in that area in the brain and in Alzheimer's disease. And ultimately, that's what results in those memory symptoms and the functional decline that can happen. But this is a key message. We know that these proteins and this pathology progresses in the brain 20 years in advance of memory symptoms. So we have this whole period of time that we can intervene on this. So if you can imagine that you had a cancer where you had a pre-cancerous state or pre-symptomatic state of almost 20 years beforehand, and if you could develop therapies and interfere with that, you had the potential to prevent those downstream consequences. And that's what we know with Alzheimer's disease now with great certainty, is that these proteins very, very slowly accumulate in the brain. In most people, they're accumulating from their mid to late 40s into their 60s, when they may start developing mild symptoms and then more significant symptoms by their 70s. So we have like a 20 to 30 year period that we can intervene on these. And this is really important within the context of brain health, but is also really within the context of disease modification, and I'll talk a little bit about that. So Jill Livingston and a few investigators over in the UK have done a tremendous amount of work over the last 5 to 6 years, showing this life course of risk factors for developing dementia. So if we look, and they break it down from early life, whereby less education, much of which has been corrected in an Irish context, but there's still inequity with that. But if you take the tilde cohort, where only 50% of that cohort, that's the Irish longitudinal study of aging, only 50% fulfilled, completed second level education, to now having 90% plus or 95% plus in most instances completing second level education, that is going to have a dividend downstream on people's dementia risk. We can see then into midlife, where hearing loss is a huge contributor. Yet again, it's one of those risk factors that's not talked about, where we see a huge implication of midlife hearing loss. Even mild hearing loss in midlife carries a significant increased risk of developing dementia in later life. Things like hypertension, high blood pressure, alcohol, obesity, those vascular risk factors in midlife. And as we come through into later life, we see things like depression, social isolation, and physical activity. So when we put all of these modifiable risk factors, so there's some risk factors such as our own genetics and risk factors that we don't know, and that's about 60%. But when we take those modifiable risk factors together, there is the potential to prevent 40% of all causes of dementia. And this is why we really need a brain health approach, in particular for people who have mild memory difficulties, whereby we're addressing any visual or hearing loss. We're looking at the diet, in particular a thing called a Mediterranean diet, which is, has an emphasis on less red meat, less processed food, more vegetables, fish, those things that we would automatically intuitively know. Looking at people's blood pressure, diabetes risk, and cholesterol in midlife, exercising being the best medicine of all, and giving people structured platforms, whereby they can engage with exercise, especially from communities such as Tallaght and other communities whereby it's not always accessible. you're actively pursuing and identifying depression, especially depression that starts for the first time in later life. We've become far more aware and far more conscious of depression and suicidal ideation in younger people, which is really important. But depression is often a very silent syndrome in later life, and often goes undiagnosed until it's at very significant levels, if ever diagnosed. And that's social connectivity and how we kind of give good platforms for people to engage in later life is so important. I always say, this is how you bring your heart and your body to the gym, is by exercising. This is how you bring your brain to the gym, is by social connectivity, and you need both. And by targeting these risk modifications, we can prevent 40% of all dementia. This is hard fact. This is science. This is absolutely evidence-based. There's nothing that I'm saying that's in any way controversial, but we haven't moved on it, and we haven't put together the platforms for doing it. And the brain health clinic that we have in Tallaght is the only brain health clinic in this country. And to be honest, there's very few brain health clinics even around Europe. So we're very slow in actually trying to get to a preventative model of medicine, as opposed to always being in that reactionary state. If we step back and have a look at these gender differences, or the sex difference in dementia risk, we have to try and look at a relationship that I've just talked about between risk factors and women and men. And what we know is that there may be risk factors with the same frequency for women and men, but they have a stronger effect on one or the other. And one of those is the ApoE genotype, which is our most common genetic risk for developing Alzheimer's disease. And what we know that, for women who have this genotype versus men who have this genotype, it seems to have a greater impact. And similarly, there may be other genetic variants that we haven't yet identified, whereby both men and women have them probably to equal, to the same effect, but they have a different effect through other interactions on women's brains versus men's brains. Then there are risk factors that have the same effect on women and men, but they have different frequencies. So, for example, women have had traditionally less access to education, and as a result, that may have accounted for some of that increased risk. And certainly, traditionally over in the US, that was one of the reasons that was touted for that gender difference. We've seen actually a relative equalization and access to education, and it hasn't leveled out, but there is almost certainly some educational impact. I think we also see whereby there's a higher frequency of smoking in men traditionally, and that may have accounted for some risk that was coming through on that side. So you can have risk factors that may have the same effect, but have a different frequency. And then we have risk factors that differ by gender in their frequency and effects. So, for example, head trauma is more common in men than women, but women are probably more susceptible to the effects of a head injury. And in fact, when we look at it within the context of hospitalizations, more women are hospitalized with head injuries, particularly in later life following falls, than men are. So there is differences in if you like the penetrance of those risk factors in some groups. And then some risk factors are restricted to one gender, such as pregnancy, menopausal changes in hormones that may happen in women, and we don't understand. And even for prostate cancer or men receiving androgen deprivation therapy, we don't fully understand how these specific risk factors are feeding into this difference in the 2-to-1 likelihood of women developing Alzheimer's disease versus men. So on to some positive news after all of that. So our current treatments, up until 2021, the last treatment licensed for Alzheimer's disease was a medicine called memantine in 2002. For 20 years almost, for this major condition, which is the leading cause of death in developed countries at this stage. And if we look at our UK dealers, colleagues who have accurate registry data, it is now the leading cause of death. It's surpassing cardiovascular diseases in older people. And what we had was essentially what we call symptomatic medicines, which improved the amount of what we call a neurotransmitter, little chemicals that help messaging between nerves in the brain. And it basically ensured that whatever brain cells were still there were working as good as possible, but it did nothing to delay or to slow down that process that might have been causing them. And that's what a disease-modifying treatment is. A disease-modifying treatment is a treatment that will remove those toxic proteins from the brain. If you like, it's a chemotherapy like we would envisage for cancer. It takes away, if you like, the toxic proteins, and as a result, it preserves any further damage to the existing brain cells that are there. And we've entered this new era, and I'll talk a bit about lecanemab, which was the very good news that we got at the end of 2022 and into 2023, which is the first disease-modifying treatment that hopefully may be able to get to the market here in Ireland. Has been licensed by the FDA over in the US, but I mean, there's still a huge pipeline. So in that we've got, when we look at all of the different trials that are ongoing at the moment, we've got 31 treatments in what we call phase 3 trials. These are advanced trials, and the majority of those are looking at disease-modifying therapy. So the future of trying to identify treatments that will definitively treat Alzheimer's disease and other dementias is we've got more reason than ever to be positive. The lecanemab is this new medicine that has, if you like, really, garnered an awful lot of attention in the media at the end of 2022, and rightfully so, because even though there was a medicine about 2 years ago called aducanumab, which is licensed over in the US, there was quite a controversial licensing piece that went on with the FDA. And depending on who you talk to for aducanumab, it was either the first disease-modifying therapy for Alzheimer's disease or the worst FDA decision in the history of the FDA. So it ended up being quite controversial, and despite the fact that it was available clinically, it hasn't been used a huge amount. Lecanemab is a new treatment brought out by ICE and Biogen, and they announced results of a study just before Christmas of which demonstrated that when they administered it to almost 2,000 people, what they found was a reduction in the decline of cognition. A reduction. They were able to clear this protein. That's what this graph refers to, is they were able to clear the protein for the brain by looking at a special scan. They were able to see that they reduced, the people who were on the medicine had less of a decline in their memory and less of a decline in their functional ability. So this was the first medicine that demonstrated that we could clear this protein amyloid from the brain. It really only targets amyloid. It doesn't target the other protein tau, but by doing so, we were able to show that we slow down the progression of people's disease. There's, of course, a huge implication for how, we were essentially entering into an era whereby the treatment for Alzheimer's disease will really mimic very closely our treatments for our cancer medicines, and that it'll be the development of far more specific diagnosis and the delivery of these medicines over a period of time to remove these toxic proteins. But we are entering an era whereby potentially, as a result of doing so, we'll be able to prevent people developing memory symptoms downline altogether. There's a whole systems readiness that myself and other colleagues have been talking about that we need to prepare for. These medicines are coming quickly and will be available over the next 12 to 24 months. But if it will require access to MRI scans, it will require access to specialist PET scans. Currently, we do trials on medicines like these in our trial center here, but actually very few centers around the country would be in a position to deliver these medicines if they were available in the morning. And that's going to be a real pressure point. So over the next 5 years, and I've kind of given a generous period of time, I think this is relatively conservative, this could happen quicker. But I think what we're likely to see is that people, around the age of 50 or so, will probably be going to their general practitioner and having, a memory screening test and a blood test, which will identify these proteins. As a result, they will be referred to a specialist memory service, seen within a month, have an MRI scan, have more detailed memory tests, and we'll have one of these confirmatory tests, either a special scan called an amyloid PET scan or a CSF test that will confirm that they have Alzheimer's disease. The most important thing is this person probably has no memory symptoms or symptoms of memory loss whatsoever, or at least has very mild symptoms of memory loss. This will not be treatment that we'll be giving for people with significant memory symptoms. Within a month, then you'd expect that they'll either be coming into an infusion room, similar to as we would have now for many of our cancer chemotherapies, whereby they will be receiving an intravenous medicine or a subcutaneous medicine, and we'll be doing scans such as these to ensure that we've cleared that protein from the brain. And over the course of 5 years, we'll be expecting through a brain health structure to be able to support people to live well with this condition. So I'm going to stop sharing now. That was kind of a whistle stopped. And you're there now.
Thank you very much. So that was really an excellent, comprehensive and informative presentation. I've learned so much in your presentation. It was amazing. I think we probably have lots of questions to ask you, Sean and Vanessa, and I'd like to invite the members of the task force now. If they have any questions, would they like to address them to Sean or Vanessa?
Peggy, there's one in there in the chat already. Actually, I've just asked people to put them in the chat.
Yeah.
Yeah, can you see that one? I think Sean has answered it, but again, you know, no harm.
There's no harm in answering. I think we need to, I think there's so much in that presentation, and it's from Sarah. So Sarah wants to know, is there any steps we can take now in our 30s and for parents in 60s to try and reduce the risk of getting dementia?
So in our 30s and 40s in particular is the time to actually get proper proactive about this. So I think there's the silent ones. One of the things that I think we've probably not been successful at doing is actually ensuring that at a primary care level, we have a health check at 50 that everybody gets access to, whereby we're checking blood pressure, cholesterol, diabetes risk, and all of those things. It is such a simple fundamental that should have been worked in and as part of our standard practice that we still haven't managed to establish. And as a result, then we have these silent conditions such as hypertension and things like that. So we know midlife hypertension, for example, is a significant risk factor for developing later life dementia. So there's these risk factors that happen in midlife: hearing loss, visual loss. Making sure that those things are optimized are really important midlife risk factors. Then if we go into our 60s, the most important thing is social engagement and exercising is so important. And that is the medicine that accumulates in its impact. So actually doing less when we're older is far more impactful than doing lots when we're younger. So it's like the SSIA dividend. You didn't matter when you started putting into it. Everybody got the same out at the end. So it's actually really, really important about having structured platforms. I mean, and I think this is the thing, is giving leaflets out to people in a clinic or just having a public health message that says people need to exercise more is ineffective. It doesn't work. Okay, from the people I look after here in around Tala and in our region, many of them don't have the access to the information in the first instance, and often you need to be presented with a platform of engagement. So yet again, investment in community exercise programs and in delivery models, such as one of the programs we use here really successfully is XWell, and giving people access to those programs is so important, as opposed to just a scenario whereby we're telling people go eat better and go exercise. It just doesn't work. So I think having very structured platforms that help older people engage is very important.
Thanks very much, Sean. And Sheila would like to know, if you want to get tested now, how do you go about it?
So, I mean, right at the moment where we're at is where anybody has any kind of concerns about their memory, first protocol is to their GPs, and GPs would always remember. GPs will be able to screen out then by doing a brief memory screener who they think needs to come forward to a memory service. It's important to say that right throughout our life we have lots of periods of time whereby our memory is good or memory is bad. Okay, at times that we're stressed, at times that our mood is low, at times that we're overwhelmed, or whichever, we'll have, it's difficult for us to concentrate. There's lots of factors that feed into it. So, temporary absences or temporary lapses aren't something that concerns. I think what becomes concerning is, especially as we get a little bit older, if those are happening more frequently. We do want to detect people with milder symptoms. The other memory service that I run is a National Intellectual Disability Memory Service. And for example, people with Down syndrome, we know that they pretty much, unfortunately, have 100% risk of developing Alzheimer's disease. And all the great advances that we've made at supporting their care in early life with regards to cardiac surgery and gastrointestinal has meant that they're all living longer. And by the age of 45 to 60, many people with Down syndrome will develop Alzheimer's disease. And what we try to do is baseline testing and ensure that we get baseline testing at early stages. So in their mid-30s, we're trying to establish baseline testing for that population.
Thanks very much, Sean. So I think Ingrid is asking, I think we may have answered that. Are there any options at this point to go for preemptive tests?
So yet again, I think the blood tests are coming quickly. I think this is all going to, I think the challenge is going to be actually the system's readiness. So if anybody has tried to get an MRI scan over the last few years, they'll know how difficult it is. And if, even when these medicines become licensed, even when we're able to identify the group of people who will be most likely to benefit from them, the actual systems readiness around their delivery. We've very few specialist diagnostic services. The numbers of people that we would be potentially talking about, within an Irish context, for example, if we take that lecanemab population, we're probably looking at easily 25,000 people in an Irish context in the morning would be eligible to come forward for that medicine.
Okay.
It's a medicine that will probably cost in or around 25,000. At the moment, they're saying $25,000 a year. And we don't know exactly, you know, how long it is that we give it. It's in that trial, it was given for 18 months. So these are going to be hugely, this is a major step change in our healthcare.
Yeah, absolutely. Absolutely. And Linda would like to know, would you envisage a screening program for people in their 40s to test for the toxins you mentioned?
I think it'll probably be in their 50s. And that's what I think is probably going to happen when blood tests become available but, you know, by the same token, we can screen for stuff now. I mean, so I don't think anybody is going to voluntarily kind of come in. At the moment, what we do is we do a lumbar puncture and we measure those proteins. And I think the procedure is enough to put people off wanting to do it just as a screening test, albeit it's very, very well tolerated. And we have a huge uptake on doing it when somebody has a memory symptom. And that's the difference between a screening program and people with memory symptoms. So people with memory symptoms are generally, when they come forward to our clinic, they're very motivated to try and find out what it is causing them. I think what's going to happen with these blood tests when they become available over the next 2 years is that, and especially if we have medicines that can remove these proteins, is that there is going to be an impetus on us to identify earlier and earlier stages of this disease. And as a result, then, yeah, I would envisage that many GPs, these blood tests will probably only cost 60 euros, 100 euros. They won't be expensive. They will be quite accessible. They're done on the exact same platforms as we do many blood tests here in the hospital. So when they come through, I think that's going to be the big step change. As much as we talk about, you know, the treatments, the availability of blood tests to accurately diagnose will probably be a big step change. I wouldn't probably be advocating it because there is lots of other side effects and caveats to these treatments, as there would be for chemotherapies for cancer. They are not benign treatments, and there is lots of monitoring that needs to be done with them. You know, so I think there will be a timely balance and debate around trying to find out when is the right time to start therapy. You know, how we go about, you know, establishing a screening program, access, making sure it's equitable, that it isn't just people who can afford private healthcare who will have access to these therapies. So there's a whole piece that needs to be sorted out almost in advance of a screening program. But if somebody was asking me in the future, did I think that's what's going to happen? I do. I think that is ultimately where this field is going. Okay.
Thank you very much, Sean. I don't see any more, Mary, in the chat. Has anybody else any questions for Sean or Vanessa?
None in the chat there at the moment anyway, Peggy, but yeah.
I'm just fascinated by the presentations, and I know, Sean, you're talking about how, you know, other issues affect dementia, for example, Parkinson's, stroke, and diabetes. There's a whole combination of health issues there that are already in the health system and well catered for. So do you think there's a sort of a collaboration there, or sort of we can integrate the area of dementia into the others, or because you're talking about awareness raising, and I'm just wondering, is that an option there?
Yeah, so the National Dementia Office have done a tremendous amount of work at trying to, if you like, cooperate with other, you know, so when we're putting out a heart health message, that we also talk about the implications for dementia risk. When we're trying to put out a smoking cessation message, we should talk about, you know, the risk of, you know, smokers carry a double risk of developing dementia in later life. We don't talk about the associated. Diabetes carries a 4 times risk of developing Alzheimer's disease. There's a transition that happens around about the age of 55, whereby the thing that people are most terrified switches from cancer to dementia. And this has been replicated in multiple studies around the world, whereby when you ask people what's the condition they're most worried about developing, up until around the age of 55, everybody says, oh, cancer, I don't want to get that. Rarely actually people talk about heart disease and stroke, almost because I suppose our medical advances have been such that maybe people aren't as concerned about them anymore. But from the age of 55 onwards, what everybody will say they're most terrified about developing is dementia. And that feeds into the stigma. That is why people don't want to talk about it a little bit. That is why I think female caregivers are more protective of their husbands and not wanting to show them up, and maybe us men aren't as protective, or maybe aren't as, and we go out and we seek support, or seek assistance a little bit earlier. Certainly in clinic, I think those are the dynamics that we see. But when we were coming back, you mentioned about screening earlier on. Well, the big screening test we can all do now is on these other lifestyle risk factors. All of that brain health piece is fully available to us now. So even without the fancy blood tests, without the fancy treatments, there is this whole suite of interventions that we know now can make a big difference.
Thanks very much, Sean. And Vanessa, I have a question for you from Sheila. Any advice in relation to family members who struggle to accept diagnosis? I mean, this is a huge issue for women and their families. It's a huge worrying issue for women and their families.
Yeah, I mean, so one of the aspects that goes with dementia is a thing called anosognosia, which is a failure to recognize. And by its nature, you can't remember what it is you've forgotten. So it is obviously that carers and people who are seeing somebody will recognize the symptoms of memory loss and functional loss much more than the person who's living with them. From the carer's perspective, it's really important that these aren't, if you like, choices that they're making, or it isn't that they're ignoring deliberately, or is their brain has created a reality that's at odds with what they experience. Yeah. They're as certain of it as I am that I'm sitting on a chair. Yeah. There isn't a room for debate. It's not like having a discussion about who's your favorite football player. It is an absolute certainty. It is an unmovable fact. So when you're pressing on and you're saying, no, this isn't what happened, this is what happened, that's why there's so much tension, because actually there isn't scope within their understanding to accept what they are determining as something that's absolutely certain. So that's the first point of view of when we're talking to people in that care role, is to kind of understand that's where the person who's living with dementia is coming from. From the point of view then of it is probably the most challenging cases is where somebody is refusing care, refusing to, to allow support in. And a lot of it is just, it changes and evolves over time. So sometimes, people will have, quite strong opinions on it initially, where there is maybe a little bit of awareness that they don't want to be showing up, or they become paranoid about strangers coming into the house. And over time, maybe that resistance drops a little bit. And there's opportunity to kind of keep working at it. I think linking in with the Alzheimer Society and getting advice from peers is really, really important. And they have their helpline, and the ASI are really, they have dementia advisors now appointed in all of the counties around Ireland who can give, both general and specific advice, and can signpost people towards local support services. Yeah. But I would never underestimate. I mean, living with dementia is the bravest existence. There is a lack of certainty of the ground underneath your feet. It's like I always sort of say, don't you know, when all of us, when we have that moment where we walk into a room of strangers and we're not quite sure how is it we're going to engage or start this conversation. That is the kitchen breakfast. Yeah. Okay, for somebody who's living with dementia. It is a very brave existence. And as a result, that becomes attritional, and people become defensive, and people can become exhausted. So when you're living in that existence, it becomes far more, you're just used to having to be, you're challenged on all of these things. And as a result, it generates behaviors, and trying to understand what might be generating those behaviors is often what's really important. But yeah, it can be very difficult to support somebody who's, if you like, refusing to accept help.
And I suppose, Vanessa, this is very stressful for the partner or the woman, the wife. This is very, very stressful.
Yeah, absolutely. And I mean, I think what Sean said there about, not being afraid to reach out for help is really important. The Alzheimer Society are absolutely excellent. They have, they have peer support, people who have been through it themselves, who know what you're going through, who are really, really useful, and who can just provide support, and just even that they actually understand, because it's probably something you don't really understand until you're in that position yourself. And I think as well, what Sean alluded to also, the stigma is a big thing that, you mightn't want to admit, you mightn't want it to reflect, you know, you feel that it's going to reflect, people are going to think, oh, you know, that there's something wrong with my husband, you know, they'll be embarrassed because he might use the wrong word about something. You know, there's that whole embarrassment tied up with, you know, the brain not functioning well, which is, you know, that's a huge thing that that is really important to work against. There's been a lot of awareness campaigns, Understanding Dementia and others, led by the National Dementia Office, that just to kind of try to dispel that stigma as much as possible. That it's not, you know, it's not anybody's fault. It's not something that, you know, you should be ashamed of, but that's, you know, easier said than done.
And just Sabina wants to ask you, Vanessa, as well, is there any link between those women who are carers, regardless of what the condition is, and developing dementia?
Oh, that's a good, I might actually pass that one over to Sean because I'm not too sure.
Yeah, so we
really
know that, well, unfortunately, we know that carers often have poorer health outcomes than people who aren't in a caring role, and that probably does extend to a greater dementia risk than women who wouldn't have to take on a carer role. There's lots of factors that feed into that carer role, you know, that can influence that. So it's not a universal principle, but certainly, if you like, a lot of the larger evidence, you know, would support that greater degree of risk. I saw Ingrid as well put in a question with regards to hearing loss, and yes, actually, there's really emerging recent evidence that demonstrates that wearing a hearing aid probably does impact and reduce this risk, which is another reason why it's important that we're screening better for hearing loss and things like that, in particular in midlife, because how we see, how we hear, how we think, we're awful at making our own self-judgment on it. You have to get them externally checked.
Thank you very much. I think we're nearing our at the end of our time. Has anybody else any outstanding questions they'd like to ask? No, but look, I'd just like to thank both of you, Sean and Vanessa. Excellent presentation, so informative, and I really feel that we've learned an awful lot. I have anyway, and I think it's so important for the task force to hear that you know, it is preventable. We can take modifiable risks and attack them basically and try and prevent this terrible disease. And also, Sean, the fact that there's also going to be new treatments in the future, I think, is incredible. And it really, I think it's an essence of hope, I think, for all of us moving forward in the future. But thank you very, very much to the two of you, and thank you for everybody for joining. And I'd like to hand back now to Mary, who wants to make some announcements about further task force webinars. Thank you very, very much.
Well, I just want to say thanks actually as well to both Sean, Vanessa, and yourself, Peggy. Actually, I said I'm hoping that I'm one of those super agers. Isn't that what you mentioned earlier, Sean? I really hope I am. I know, but again, what I got from all of you is the hope. You know what I mean? That again, that there is progress going out there, and there is hope, and that's great. Remember, this session was recorded and it will be up, and the presentations as well, actually, hopefully, will be up as well for anyone to view and go back on as well if you want any links or anything like that. We have another webinar coming up next Tuesday, actually, on endometriosis and how we can help break the cycle on that. So again, the link will be going out later today. I didn't want to confuse people with the two webinars, but I have to say thank you very much to everyone who attended for their time, and especially to both Sean, Vanessa and Peggy. Much appreciated, and thank you very much for everything. All right. Thank you, folks. Bye. Thank you. Bye.